Tyler, welcome. It's good to finally have this discussion. I know we've
Yeah.
been running into each other at a number of networking events over the past several months, so I'm glad to sit down and have this conversation.
Yeah.
But I want to dive right in and ask you, as it relates to what you do at work, what is the mission that you are personally on right now?
Yeah, I think that's a great question. I think it's really important to understand the why any of us are in this industry. I think the why is what differentiates people who really are in it for the right reasons and for those who are just in it for a career. For me personally, working with a variety of older adults with my last couple of jobs, and then as well as personally with my own grandmother who ultimately succumbed related to Alzheimer's disease. She had a heart attack ultimately, but she was a really, really brilliant woman. She was an art teacher for
Hmm.
elementary school, and one of the smartest women that I knew. The type that would come, home from the library with a stack of books this high, and it'd be gone in a week, and she'd be back to get more. And
Yeah.
this is around the time when I was in undergrad, and so I didn't get to see her as much. But when I came home, every time I did, her intellect degraded a little bit by little bit up towards near the end where she really didn't remember who I was. I remember going to it was my grandfather's funeral, not her
Yeah.
husband, my other side of the family. And, just like, who are you?
Yeah.
And those things, I didn't understand dementia quite like I do now,
How old
but
were you at this time?
I was probably, what, 22, 23,
Wow. Okay. Yeah.
probably 22, because I was still in college. And, it kind of left a mark. And after being in the industry for a while, it's like, boy, do I really just wish I had the resource that I had now for her then. And if I can do that again for other people, I mean, that's a life worth meaning.
No, I love that. And, it's so interesting because, I'm in healthcare, and everyone that we run into that is in healthcare oftentimes has some sort of, personal history or personal experience, whether it be a family member
Yeah.
or somebody that maybe drove them toward that specific field. Now you mentioned some maybe memory impairments with your grandma, and I guess why don't you? It'd be a good segue. Like, what is it that you're actually doing
Sure.
now with your scope of work?
Yeah.
And yeah, can you tell us a little bit more about that?
Yeah, so I mean, I had a really great opportunity after living and working in Maryland for a while. I did home care in DC. I did hospice in Montgomery County, Maryland, and I worked as a aging adult life care manager for Johns Hopkins on an outpatient
Okay.
basis before that. But an opportunity came up to come down to Northern Virginia for the opportunity that I'm currently working with, and this is called GUIDE. GUIDE is an acronym that stands for Guiding an Improved Dementia Experience. GUIDE.
Okay.
And that's what we hope to do is be able to help guide people who have living with dementia and their unpaid family caregivers. So that's kind of, in a very quick nutshell, what this new program is about. And I'm happy to get a little further into what that looks like.
Yeah, absolutely. And so you got this opportunity in Northern Virginia, and so is there like a larger company that this is a part of, or like tell me a little bit more about
Sure.
that specifically?
Yeah, so this program guide is a nationwide program,
Okay.
but you have to be able to bill Medicare Part B in order to participate in it.
Yeah.
So the company that I am a part of is Five Star Home Health. They ascertained the ability to bill Part B in order to get granted this program last July.
No, I'm a physical therapist since 2012, and the first time that I met you at a networking event was the first time I heard of this
Yeah.
program. And I had worked in a number of assisted living facilities, as a PT, and this was just not a resource
Yeah.
that I ever came across. Is this a newer program, or like has this been around for a while?
It's definitely on the newer side. So
Okay.
CMS, the Center of Medicare and Medicaid Solutions, piloted this last July for the first track program, which we're a part of.
Okay.
There is another wave that's launching in July of this year, just here in 2 months or so, actually a little less than at this point. But we were in the what's called the first track, and so it was less programs started then, and more will start here in July. But it is within the year or so new.
Wow. Okay. Yeah, so that would explain it, and maybe why I hadn't really come across it so far. But it's something that I wish existed when I was treating, because so many of my patients that I was working with had dementia, and despite the fact that having, physical therapy, occupational therapy, speech, and all of the services, there's still a missing link. And it sounds like this is maybe filling a lot of the gaps or the holes that were in the traditional care model. Is that fair to say?
Yeah, I think it certainly is providing a holistic look into helping both not only the person living with the disease that is the broader term of dementia, but also the people who take care of them. I'm sure in your work before too, you came across the husbands, the spouses, the daughters, the kids, the grandkids, even who were the ones who maybe opened the door for you to get in to help the person to do that work, that physical therapy, or there's so many people behind the scenes beyond just the person living with illness, especially with something like dementia. And this program I think is really unique because we don't just solely focus on the individual living with the illness. A large focus is actually on helping the individual caring for that person.
Yeah, that would make a ton of sense to me. Now, I mean, obviously folks who are suffering from dementia would benefit from this, but like who are the ideal families or patients? Like who benefits most from Guide, I guess?
Yeah, so I mean, I think that's a great question, and that kind of leads into the conversation of who is it even for? Because you might be hearing this, and it might be, oh, this sounds great. Maybe this is good for mom, grandma, whomever. As I kind of gently alluded to earlier, this is through the Center of Medicare and Medicaid Service, CMS.
Okay.
So this is for people who have Medicare A and B. This is what's through the Innovation Center of CMS is who's piloting this. And what this basically is, it's like a think tank. It's a incubation for new programs that aren't fully a part of Medicare. But this has been piloted for 8 years as of last July, so 7 more years coming forth. And the hope is that this will become part of Medicare long-term if the numbers are there. But this is specifically for people who have Medicare A and B, as this program is reimbursed through B. And the greatest part of this all is for those who are eligible, it is 100% free, no cost to anyone. So you have to have A and B, but it is at no cost to the individual, to the person taking care of the person with dementia.
Yeah. And
then kind of leading into your next point is who's it best for? This program can exist for someone in the home, living in their home, aging in place. This could be independent living or 55 plus community. This could be assisted living, or this could be a memory care. So kind of your continuum of senior housing outside of the nursing home.
Right. And I would guess that has a largely to do with Medicare billing and how if they're in a skilled nursing facility, for example, they're already billing Medicare Part A and just how that all works together.
Yeah, exactly. I mean, at the end of the day, it's all about cost savings in healthcare. So, we want to be able to help that. And that's why Medicare ultimately is piloting this is to help people, but also to help keep those costs down because it's expensive to fund insurance for everyone. And if we are able to keep our costs down across the board, it ultimately helps everybody. So that's one of the big things is the nursing home for short term bills Part A. The nursing home for long term, a lot of times someone spends down and gets Medicaid, which CMS is also in charge of, and then they use Medicaid to pay for that room and board. Otherwise, it's very expensive private pay. So either way, with a nursing home, Medicare's footing more of a bill. AL memory care, private pay. They don't have to worry about it.
No, that makes sense. So who are the folks that are actually delivering the pieces of or the entirety of the program, I guess, to the folks with dementia and their families?
Yeah. So there's a couple different phases and steps to this and a couple different people and specialties involved. The most constant and ongoing person through all of this will be the dementia care navigator, but I'm going to come back to that because they don't start there. So the process is going to start with a physician doing the comprehensive assessment. Him or her and their assistant, in this case, we utilize a MA or a medical assistant, will reach out to a family and ask some questions. You're going to do some scales.
Is there a specific physician that does this for you guys or like a group, or can any physician do this?
So it is meant to be that any broader physician can do this across the program. So us individual, we use our own, our skilled home health company's medical director is the one doing it. So you need an MD, MP, PA, DO. You need licensure to sign off on this. But in this case, we have our medical director who's a retired emergency room doc, and I think he's 40, 50 years of experience in the industry. He's the one that's doing that. They're going to ask some questions. One thing is called a CDR, a clinical dementia rating scale. We actually, again, going back to my point of focusing on the unpaid family caregiver, we do what's called a ZBI, or a Zaret-Barrett inventory. This is a stress inventory for the caregiver of the person with dementia, because we track this throughout the program, ideally trying to help out. So that stuff's done early on.
To objectively measure the impact that the entirety of the program is providing.
Yeah, exactly.
Okay.
Yeah, and we're quantifying, we're making sure the person's appropriate at this stage. We do that if the physician agrees that this person is, in their eyes, eligible for the program. We then in turn take that and submit this data in a very specific way that Medicare has asked for to them to say, is this person appropriate or not? Okay. It is insurance. We do have to wait 14 business days to hear back. But after that, we either hear someone is approved or not. Their term is aligned or not aligned. So at that point, if that person meets the criterion that CMS thinks, they're approved. And then we can start to move forward there.
Okay. And aside from them having Medicare Part A and Part B, do you know of certain things that they're looking for that would say, yes, they're aligned, or no, they're not aligned?
So ultimately that CDR, that clinical dementia rating scale, is what the tool that Medicare will be looking at on the back end. Okay. But it could be things like impairment to ADLs, activities of daily living.
Yeah.
So, if someone's having a hard time carrying, grooming, feeding, walking, traveling, getting to their own appointments, things like that. And then, of course, it's a memory screen, because this is a cognition disorder. So if they're having a hard time remembering things, who they are, where they are, what year it is, things like that, those are some of the things that we're going to be looking at as criterion. Ultimately, if someone is formally diagnosed with a dementia diagnosis and has A and B, they have a likelihood of being approved. This is just to quantify it.
Right. Yeah, and like anything else with home health, there's your ratings that they're going through. Anything. So it seems like there's a specific tool that's being used, right, by the physician is doing this,
and
right?
The MA, their medical assistant, are helping ask and administrate a lot of it, and the physician's like reviewing it and then calling it back.
Now, is that in person in the office?
This is a telephone. That's a good call. That's a good observation, but it is a phone call. This is
wow. Okay, so it's fairly easy for them to administer.
Yeah.
That is interesting. I would have thought they would have need to see the person in person or virtually, for that matter, right, to be able to make the assessment. But I guess it's just over the phone.
And I think that paints a good example of a lot of this program, is why it's accessible, and especially for maybe people in more rural areas and things like that, is because it's heavily done telephonically, Zoom or Teams. The next stage after all that, assuming that person's approved, is the in-person stage.
Okay.
And that's called an in-home assessment. So if they go through all of that and they're aligned or approved, the next thing we schedule is an in-home assessment. And this is a dementia proficient and friendly home health clinician. So might be an OT, occupational therapist, PT, physical therapist, speech. It could be a PTA,
somebody who actually has experience doing this.
Yes.
It's not just like the PT that's been treating orthopedic knees or something.
But it's somebody who's PT. It's a home health clinician who's used to seeing this type of population. We do give some additional training on top of that. And it's certainly just not nobody. It's a clinician.
Right.
So coming out. And they do a couple of different things. They're going to look at the medications that person's on. Medicare has asked us to look at high-risk meds. So they want to reconcile or take note of the medications that they're on. Yeah. We want to look at the risk of fall, especially if they're in their own private home. Is that place safe for this individual to live in, given their diagnoses or comorbidities? Do they need something like skilled home health Part A benefit to come in? Do they need something like private duty, out-of-pocket CNA services to come in?
Yeah.
Do we need to facilitate resources? And also, especially again for that home patient, how many times, it might have been 3 or 4 years since someone was in that house last. Is it safe?
That is a very real scenario, and the amount of times I would encounter those situations going into people's homes. Obviously, we're as a PT, the hat that I put on is like, is this environment safe, and are they able to navigate their home, and what sort of resources do they have?
Yeah.
But all of that becomes even trickier, I suppose, or more of a challenge when somebody is either in the earlier stages of dementia, and now it's like you're wondering, are they going to potentially be in a harmful situation if they don't have the appropriate resources?
Exactly. So that's why that's so valuable, and that's why, at least I assume that this is why that one is in person, because the rest of the program really is more phone based or virtual.
Yeah.
And I think that's so important to have that, because that gives a glimpse into it. And yes, this patient can also exist in a assisted living or a memory care. That in-home visit will still happen in person, but it's a little easier because we can go to the nursing station and get the meds from them. We like to think if you're paying $10,000 to live somewhere that your room is safe and not a fall risk for you, but we'll take a peek. So you never know.
Yeah, like, we're still gonna trust after verifying, right?
Yeah, so that all goes on, and we gather some more data. We get to meet them in person at that stage, and that's pivotal for all of that. And then this is kind of going back to where I segued at the beginning. The dementia care navigators get involved next.
Okay.
So this is someone who has minimally, Medicare requires 20 hours of training, classroom and experiential training, as well as experience working with this population. It could be someone from a social work background. It could be someone, we have a couple who are trained home health clinicians who went through training with aging life case managers to be at the forefront at their knowledge and ability to do so. Or they could be someone who's already working as a case manager or a social worker. And we have a couple different types of people who are doing this role, but they have proficiency with the population. They understand community resources, care planning, the disease states, and things like that. And they're involved, and this is the person who will be involved with you for the rest of the time that you're on. Every month, you get at least one phone or video call from them.
Okay.
In the beginning, you get a care plan, so this is going to generally be with the person who's caring for the person with dementia, because our patients themselves often aren't the best historians, or maybe not reliable to give factual information. And if they can, we certainly will. They're welcome to be included, but oftentimes it's going to be with the brother, the sister, the wife, the husband.
Are there scenarios where the person with dementia doesn't have family or support system?
Yeah.
And then in that case, I mean, do you refer to other services, or like what do you do when you encounter something like that?
Yeah. So we have to make a purposeful effort to identify a caregiver. That's part of this program in the early on stages. Okay. So maybe someone comes in and they say, "Oh, I don't have anybody." And we start to dig a little bit deeper. Like, do you have a cousin you talk to every quarter of a year?
Right.
And well, maybe. And we can try to get them involved and say, hey, are you willing to be, considered the caregiver? Are you willing to help out? I know we've been talking with so-and-so and they're struggling and they don't have anybody. What capacity do you have to help? So, we're going to make a real effort to try to identify that, even if that person's international. We've had that come in before where someone was in Scotland and that was the only family member.
No kidding.
Figure out time differences, figure that out, but she wanted to be involved. So first and foremost, we will try. If it is someone truly in a later stage of dementia without any caregiver, family, or paid, they're a massive risk to themselves. That's generally going to be an APS call, Adult Protective Service call, because if you're a wandering risk, you're a self-harm risk, you're a fall risk, how are you taking your medicines if you don't know what today is versus yesterday?
Oh, did I leave the stove on?
It's kind of rare to find someone that late, because usually the police have got contacted,
or they may have they may have gone to their physician, or that home health may have been in there, they identified it and they had to make an APS.
So it would be a referral to appropriate if we do come across that, because that person shouldn't be alone. A late stage dementia patient should not be living alone. They need to be in a program, in a housing opportunity. If they don't have funds, they can be awarded to the state and work through the Medicaid system and look at that way. There are things that exist, but they shouldn't be living alone.
Yeah. And now, so with the care manager, right, and you mentioned at least monthly Zoom calls or phone calls. What are the, and I know it's going to be case specific, but what are they typically doing at that point, and how are they helping the family?
Yeah, so that's really what that care plan comes in that first meeting that they have together. And that you kind of will lay out, what is it that you need to work on? Let's say, hypothetically, that you're the person caring for a loved one with dementia. It's, TJ, like, what's going on? Like, what are you struggling with? What's going well with mom, and what's really been hard? Do you have food in your fridge? Do you have an ability to get her to her appointments? Do you try to jump out your car when you go? Like, if we need to get us, transportation service involved, let us know. Yeah. So to your point, it'll be very tailored. But that's going to come from those open-ended questions and that dialogue early on. And a lot of times, you may have had this too. If you work with someone who's in stress and crisis, you don't have to ask. It just comes out.
Yeah.
And you kind of meet them where they are and say, how can we, make a list, make some action items, if it's a referral to this place or that place, and kind of start there. Some common things that I have seen us utilize this time for could be chronic disease state education. So disease is a chronic disease. It means it gets worse over time.
Yeah.
So what does it look like now? What should we expect? When do we need to get certain people or places involved? What is the difference between Lewy body and frontotemporal and vascular dementias? Because a lot of people have heard this term dementia, but they don't know the differences between them. They know
it's like under this big umbrella, and it's like dementia. Okay, mine's more forgetful, but what does it actually mean, and how does that really come out with these different types? Exactly. So there's a big education piece. It sounds like.
Exactly. Alzheimer's is the name we hear and know, and it is about 80% of diagnoses. But Lewy body exists, and that's going to have a lot more psychosis at a younger age a lot of the times.
Yeah.
Most of the time, the Alzheimer's that comes very late, if at all. So knowing that, it changes how you interact with that and how to be the best, partner for someone who's living this. So it could be that. Maybe, they're thinking about, mom can't really stay in a home anymore.
Yeah.
What about some vetted options to know where you can move to, cost, tours, who to talk to, places that, might be a good fit, might be further away, might be closer, maybe what level of care? Because that's a confusing question too, IL, AL, memory care, it's nursing home. Which one's right? Independent living, assisted living, memory care, nursing home. Where is it and what can you afford and what's best for you based on where you are? Those are all questions.
Yeah. And I'd imagine, the caregivers, specifically the adult children, I've come across this sometimes as well. They actually are very involved with mom and dad, right? And now they're in that sandwich generation, I guess. They have kids of their own.
Yeah.
And they're also trying to figure out what to do with mom and dad. There's probably an immense amount of stress. They have their own lives, but they want to do what they need to. And like you said, AL, IL, all of these different acronyms. What's going to be right? What should I expect? What's this going to cost financially? I'd have to imagine there's a lot of underlying stress.
Oh, yeah.
And to have a team of experts that are in there to help guide them through that, even just for them to be able to unload and say, this is what I'm experiencing as the caregiver, brings a ton of value in and of itself.
No, for sure. And that means we can help point to support groups. There's so many things out there that people don't realize. The Alzheimer's Association does so much stuff. There's a lot of nonprofits in this area that do a lot of stuff. If you're the person you're caring for has, Lewy body, for example, it can look different than other dementias. There's a Lewy body support group out there.
Right.
They're specific to what you're going to. It's wives of people who their husbands are going through it. It's the flip-flop. It's the grandkids who are, because the parents aren't available, that they're doing it. And there's people out there like you that can get that help and connect to those people, and we're happy to help push in that direction. There's that, maybe you need to get a elder care law attorney involved. And, it's just so much names, there's so much information, and let us help, kind of figure out what those needs are, what's urgent, what can kind of wait a little bit, and act on those things. And if it's something that's way more than we can handle at our once or so month, interactions, we'll refer to people and other options out there. There's case management options, there's private options, there's things that are through the county or through the state. There's other ways to get even more support as well. So it just depends on what's right for that individual. But you don't know until you have someone to help out a little bit.
Yeah. No, it seems incredibly valuable. And I just had a thought on this. It seems a little tangential, but if somebody with dementia, maybe they're in assisted living or maybe they're at home and they're already getting home health services from, say, XYZ home health company. They have a nurse, a PT, an OT in there. Maybe they had a fall or whatever it is. Does that preclude that, or I don't know, get in the way of them getting these type of services as well?
No, and that's a wonderful question. I've been asked that before too. And the beauty of this is being a Part B biller is it doesn't get in the way of other services. So if someone is getting home health at the same time, we can continue to stay on. We actually get some referrals internally from our own home health company.
Sure.
And they're still getting their skilled services, and then we can start with them as well. And then down the road, when they need those skilled services again, we can bring them back in. So it is going through Part B, but it doesn't turn off any other faucets, if you will, of ability to use things. The one example of that where it would is if they went into a nursing home and ended up staying on long term. Another example is if they go into hospice. Yep. Hospice, I used to work in hospice. It's a total level of care. It's meant to encompass everything. It takes over Part A billing.
Yep.
In that case, everybody has to get out. You know,
yeah.
It doesn't play. Yeah.
Yeah, and so I mean, on the wound care side, it's funny is we can pretty much treat the patient wherever they call home, with the exception of if they're in, you know, the short-term side of a skilled nursing facility or they go hospice. But really, any other scenario, we can go see them.
So yeah, it's a great point too. You know, a service like yours can exist at the same time as our patient. So let's say someone is aging in place in home, or that they're in a assisted living and have been there for a while, or they're in memory care and they need your services. We can directly refer to what you guys do, because again, it's not overlapping those services.
Right. It would the way I see it, because I mean, we're a medical practice as well. We bill Medicare Part B for wound care. It would be like the patient going to see a cardiologist, Correct. Going to see their nephrologist, or Correct. Different specialties. So there's no overlap of services. And we could be in there, you could be in there, home health could be in there as well. And really, that's oftentimes going to be the best coordination of care for the patient anyway.
Yeah, and that's almost what we want. We want to be able to give them, like, the whole point is to be able to give our older adults as many resources as they're eligible for.
Yeah.
So if you're a veteran, tap into that too. If you're, if you can get skilled home health, tap into that. If you're a little further along and you get palliative services through Part B prior to hospice, get in with that.
Yeah.
And build up those resources as much as possible. And I think that's what it's really all about, because if you can get it, if you're entitled to it, utilize it. And I think that's so valuable. And then the last really big piece through all this I haven't mentioned yet as well is individuals who qualify in the moderate or high tier from that initial assessment I mentioned earlier.
Yeah.
They can access free respite care through this program as well.
Oh, wow. I mean, for those that maybe are not familiar with respite care, like, what exactly is that?
Sure. So we think about the term respite. It's a break from, right? Yeah. So when we think about what we're doing, we're working with people with dementia diagnoses, Medicare A and B, and we're working with the people who care for them. So in this sense, this is be able to take a break from their unpaid duties, which I'd reckon is some of the hardest jobs out there, to be able to take care of themselves. In this case, through Guide, there can be 3 different ways to do respite care. And we've done most of it through this first one, which is private duty CNA care. And so this would be the home care type company. And you can get 80 hours of service completely free to the individual if they qualify. It has to be in 4-hour blocks, but 80 hours per year that you can use at your discretion. You could do just 4 hours here and there. You could do 8. You could do 3 days of 20, 3 days of 24. Checking my math.
What is the math on that? But
and as long as it stays under that 80 hours per year, this gives the individual one-on-one CNA care. Mm-hmm. And it gives the loved one a break to go to their own doctor office, to get their hair cut, maybe to go out of town for a little bit. And this is huge because they're working 24/7, unpaid for this person. So that's huge. And that's the way we've done most of it. But respite care can also exist through an adult day program or through an assisted living. We just need to have partnerships with them. We have a contract assigned, and they have to accept the rate that Medicare gives us, et cetera. But it can be through one of those 3 ways, and that's every year that someone's eligible in that moderate or severe based on that initial assessment.
Yeah. You mentioned through an assisted living. I'd have to imagine this program would be incredibly beneficial for the assisted living communities that are out there. I mean, is there any reason they wouldn't partner with you aside from not knowing that Guide exists?
Yeah, I mean, it is an insurance level reimbursement, so it's going to be lower level of reimbursement than they would charge privately, market rate. A lot of assisted livings want, 30 days, 60 days, 90 days guaranteed. Yeah. I think it's about 9 days through us, but it would be free to them. The hope would be that they would ultimately move into their community, which would be obviously highly worth it. But I think that's kind of where some may balk a little bit. Is like, oh, it's, like a little less than half my rate that I would normally charge. And you're telling me they could come in for 1 day and then leave? Yeah, they could.
Right. But also just think about the logistics of somebody moving, even for a temporary
they have to do all these assessments and all.
Right. And so even on the individual side, like not the assisted living, but they're much more likely to move into an assisted living that they have some experience with, I would think. assuming that they didn't have a terrible experience.
And it can work to trial it. And I think that's just getting the awareness, me doing my job and getting out and getting into these communities and talking about it and having them see the value that comes of that, because that same person may never have even considered it if they had to do a 90-day, $5,000 or, whatever, $20,000 respite stay.
Yeah.
So it can be seen that way. It's just, you need someone to be on board with it, I think, ultimately.
Right. Yeah. And if they can see that as, that transition where they get to know the individual gets to know the family gets to know the community, right? And you provide that respite care. More likely than not, and there will be some cases where they decide not to transition that loved one into the assisted living, but I would think the likelihood is going to be much higher that they would go there if they are going to make that transition at some point.
Yeah, no, so, it's a lot, to your point, it's a lot of effort to get them there if they're not going to, they have to be at least somewhat thinking about it if they go that far. But I think there's some other valuable things for the communities as well. I think it's very easy to hear all of this and think, oh, this is perfect for the patient aging in place. I agree. But I think there is also things for the communities. That respite care for a patient that's in an assisted living or memory care, if you pretend you're the director of nursing, the DON right now, right? I can help bring you a care ratio that you could only dream of, and it's free for that person for a little bit of time. If you have 12 to 2 dozen of your patients on guide at any given time, there could be an extra CNA on the floor constantly.
Wow. So that is super interesting, because I think, the nursing directors, the EDs in these buildings as well, they're constantly dealing with staff turnover and shortages, and to be able to have, especially on their memory care unit, correct, right, where maybe half of them or 3/4 of them are on guide, to strategically pull in these respite resources. If they're like, oh man, we know, for this month we're going to be really short staffed, we need the extra help, and then to use that, at that time.
And it ultimately, as long as it's respite in nature, so we're helping out the adult caregiver, which ultimately, if there's a poor care ratio, that's going to stress out the care.
Yeah.
We can be kind of flexible with those things, and I think it's thinking about that. It's like also another example. Let's say you're an IL/AL memory care, and you're moving someone from AL assisted living to memory care, and that person's going through what we call LOC, or level of care change. That's stressful. As the family caregiver taking care of this person, if I know that I can have someone there with them for that first weekend, even though I can't stay overnight, there's a lot of value to that. Or that patient who's maybe having more psychotic outbursts, who then, takes a lot of attention, who then in turn leaves other patients with maybe less than ideal ratios.
Yeah.
Same kind of thing. You can't be a one-on-one, and no community can afford one-on-one care. And if the patient loves this caregiver, after they're done with their respite care, they can hire them privately to continue to work with them. And they may never try it otherwise. Or, I don't want to spend money on that, but then they realize how great it is.
You get a free trial for X amount of hours, and develop that bond or relationship, and it could open the door there
to us or somebody else, or anytime again, speaking to you as a director or a director of nursing, anything that can help your care ratios, decrease your hospitalizations, and help people get better care. I mean, it's there.
Yeah, it's a win-win. Now, I know we've spoken a little bit about this, but you cover a pretty large territory all throughout Northern Virginia. I suppose the question I have for you is more a personal one, but dealing with Northern Virginia traffic, covering, I don't know how many counties or territories, but what keeps you going? Because I see you everywhere. You're in the community, and you're constantly going, really trying to bring awareness to this really valuable program that is rather new. But what keeps you going, pushing day in and day out, even when things are not the greatest, or you're sitting in 10 hours of traffic?
Yeah, this is a new program, and you feel that at times. It takes time and effort to get out there and get the awareness out. And sometimes it's like, oh, I'm showing up to this and doing that, and I feel like you're not making progress. But then you slowly do see those things unroll. And I think at the root of it, at your question, I think is, again, knowing there's so many people out there that don't know about this that could benefit. And if I'm not getting the word out, that people won't benefit from it. So it's, all those people I think of a memory care community, probably 75% of those people have Medicare A and B and a dementia diagnosis.
Right.
Like, how many people in there could benefit? The people that are in their homes aging in place, that could benefit. If the message isn't being delivered, there are people who are suffering and are alone and in silence and aren't empowered. And we might be the first voice of reason and knowledge for them. And I think that's really helpful. I go back to my analogy of my own family member earlier on. Like, if I was equipped with the knowledge and things that I know now, I could have done a lot more. And not to say that it's like a sense of guilt out of that, but like wanting to be able to give back and help those who would benefit, and the family members that are just going through it. I think that's, at the end of the day, what drives it is to get the word out and help as many people as possible.
I love that. And if you had this knowledge, or even if this program existed when you were 22, is there anything you would have done differently, or maybe viewed the situation?
I mean, even now, I joined this company in December and had launched in July. I wish I had been involved earlier on while it was like formulating and getting going. I feel like there could have been even more I could have done. But I mean, I'm glad Medicare is doing something that's and not just reactive. And I'd hope to see that happen more and more. It's, I don't know. I probably wasn't in the right place to do what I'm doing now then either, though. So It's just like I was just in or just out of college at that point, and so still figuring life out and who you are, and we still are. But it's, I don't know how much could have been different per se, but I mean, I know if we had started it, how old am I now? 8, 9, 10 years ago, a lot of more people could be helped. But you can't change that. So what we can do now is grow this. And to mention your points, we're personally able here to do this in all of Northern Virginia, and we're also in the Northern Shenandoah Valley. So I go up to Winchester sometimes.
Yeah.
We're in Front Royal, and we're planning to, I should say, opening a Fredericksburg office before the end of the year. So that'll add a couple more counties down there. So anywhere that our home health team goes, I can go, and this program can go.
Yeah.
And if we can't serve you with where you're at, this is a nationwide program. There's a website on CMS's website where you can plug in a zip code and see what's around you. I encourage people to do that, or reach out and we can help try to direct you. And then in July of this year, a lot more guide programs are going to launch. Right now, we're the only feet on the ground ones in this area.
Yeah.
But a lot more coming in July.
I mean, that's good to hear. It's amazing to hear you speak so passionately about this, and I can get some of that, just that link between you being a 22-year-old kid and having to deal with that personal experience and to where you are now. But I get the sense that you carry a pretty large weight of responsibility, and it's as though if you don't get the word out there, who will? And it's not like you're showing up because you mentioned this specifically in the beginning. This is not just a career for you, right? This is something you're driven by. It seems like a larger purpose, something that keeps you going when the times are when the times are tough. And I respect that tremendously. So I just wanted to point that out because I think as more of these programs become available, and we start, my hope is that we start to see a lot more of this, and then the awareness is there. I want Tyler to be, when you think of, oh, mom has dementia, or my resident in Sunrise Assisted Living has dementia, or whatever it is, I want you to think of Tyler Lloyd and to be your first call to say, okay, how do we initiate this? How do we get the resources that we need for Mrs. Jones, for mom, for dad, for whoever it is?
Yeah, I mean, that's kind of like what I try to imprint when I do in-services or do a vendor fair. If it's Medicare A and B and dementia diagnosis, and you're in this region, guide. It's free. It can help out. And then if you try it and you don't think you're getting anything from it, just drop it. It's free. If you don't contact us for 8 months, you'll get dropped by Medicare, not us. So, there's really besides a little bit of your time. And if, you're already caring for somebody unpaid 24/7, one phone call a month is nothing on what you're doing. If you care that much, you care enough.
Yeah.
So that's the only really commitment with it, is that we do have a 24-hour phone line for after hours. It's triage. Right now it's manned by an RN. So there's a triage line. You have that respite care, so you can have a break. You get the dementia care navigation. And there's resources and ability and to connect with people, and it's a free resource. So that's the way that I look at it. Like if you're doing this, don't do it alone. You have some help. You have some resources.
Right. No, I think that's fantastic. And what I'm going to do is make sure all of your contact information, website, phone number, email, all of those things will be in the show notes, so it's easily accessible. Because what I think of is, every family, every executive director and director of nursing at an assisted living facility, every home health, all the directors, the nurses, the therapists who are out in the field treating these folks and see this. Like, it should be instantaneous, where like, oh, okay, yeah, let's give Tyler a call, or at least that should cross their mind, because again, it's a free service for these folks, and I think more resources is better than less, and most people don't have the amount of resources that they actually could have.
Yeah, no, and I think it's super unique, and there's no income disqualifier to this or anything. I mean, it really is like no strings attached. As long as you qualify. Yes, a lot of time people who continue to have Medicare A and B have more means because they continue to pay the deductible. That's why some people opt into Medicare Advantage or spend down to Medicaid. But for the folks that maintain this, and the hope is that this program can show the value, and that this leaves the innovation center and is baked into Medicare ongoing. And then we can use this as a model for other chronic disease states like CHF, chronic heart disease, and diabetes, and other things that are very expensive to the system, very detrimental to the individual. Build this out so that maybe one day we can have this model for someone with diabetes or congestive heart failure, or pulmonary disease, things like that. And that, I think that is a much more, as I said earlier, reactive, preventative approach than a reactive approach.
Yeah, makes sense. Are there any questions that I didn't ask you that I should have, or anything I missed that you'd like to maybe share before we start to wrap up?
Yeah, I think we kind of went through most of it. Again, I'll just continue to reiterate. It's Medicare A and B, dementia diagnosis. So this needs to be a formal diagnosis by an MP, PA, MD, or DO. It can come from a lot of different places. Yeah. The more info we have, the better, but that's truly all we need. And they have to have active A and B. If they move into hospice, that disqualifies them. Long-term nursing home, if they go in for a short stay at a rehab and come back out, as long as it's under 90 days, that's okay.
Okay.
And then PACE is another disqualifier. It's another innovation center program. If you don't know what it is, you probably don't need to worry about it. But if it does, it will, impact if you need to go that route. It's a great program, don't get me wrong, but it serves a different purpose. And then that's it. Or if you move out of our service area, or swap out of Medicare A and B.
Sure.
So those are the biggest things. Happy to be a resource. We have you can call or email or go to our website and fill out a referral form, which I think you said you'll share out.
Yeah, I'll make sure everyone has all of your resources. Like I was saying, this is for you. If you are an executive director or director of nursing in an assisted living, or maybe a home health, a non-medical home care, anyone that works with seniors, and you are dealing with the population, the dementia population, and they don't have these services, Tyler is the person to call in the Northern Virginia, Winchester, Fredericksburg, pretty much anywhere in Northern Virginia market. But Tyler, I appreciate you taking the time, my friend. So
likewise.